Hey, well, welcome everyone. So great that you are all able to join us today. So before we get started, I'd like to start with our land acknowledgement. And as this is a hybrid event and some folks are in different locations, please take time and space to give thanks and gratitude and respect to the land you're currently living and working on. Today, we're here on the York University campus in Toronto, which is the traditional territorial area known as Toronto. And the traditional treaty holders are the Mississaugas of the Credit First Nation. But we also acknowledge this as the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably care and share for the Great Lakes region. And just this weekend, I was reminded by a story in the Globe and Mail about the Indigenous peoples, and they were the first ones to extract maple syrup from our trees in Canada. And, when the settlers came, they basically forced them off the land, or they gave their land to farmers, settler farmers who cleared the land for agriculture, or they, did clear cutting to put roads through the area. So our Indigenous groups, especially in the Lake Huron area, north of Toronto, of course, and in our northern areas, they faced a lot of these challenges, but I'm happy to say that they've been able to rebuild and incorporate new technology and investments, and they're very big into maple syrup extraction now. So just a small tidbit, but today we're extremely delighted to be able to host Professor Benedict Weobong, who has degrees in psychology, mental health epidemiology from the Universities of Ghana and London. And as a global mental health epidemiologist and academic, his research portfolio is being informed by the principles of global mental health along 6 strands: understanding and addressing the social determinants of mental health, developing and evaluating psychological treatments, implementation research in routine primary healthcare settings, school-based health and well-being programs, research agenda setting, and training. His current lab holds 3 major activities: climate change and mental health, developing measures tools for relational well-being among youth, and developing step-up care intervention to treat depression and anxiety among adolescents in Ghana, as well as evaluating the implementation of a routine health checkup program for adolescents, and building a critical mass of global health researchers through doctoral and postdoctoral training. So thank you so much, Benedict, and over to you.
Thank you so much, Mary, for the introduction. I would like to stand up as teachers. Well, that's what we normally do, isn't it? Yeah. Hope you can succeed. All right, so thank you for having me here today. I hope I'll be able to get through my slides in half an hour, correct? And I'll be sharing with you what I think is the first in the series of my thoughts of some experiences around how we could possibly reach adolescents with health services. And today I'll be reflecting on one of our projects called Y-Check, where we try to develop a routine health checkups intervention for adolescents. And hopefully the next time, or when the opportunity presents, do
we have a maybe that will be easier if you're standing.
Yeah, when the opportunity presents, hopefully I will share with you some of the work I've been doing, more targeting mental health of young people. I just want to start off by giving and recognizing my team members and from Ghana, but also WHO, and for all the effort we put in to get to this stage, and the plans for next steps. So these are some of my team, obviously not all of them, but a number of them that are quite playing critical roles in this work. We have our PI, overall PI from WHO, Prena over there, and then we have David Ross, who actually was the one who conceptualized this idea and asked that we should be up. Yeah, there's something here I want to get off. Okay, so what are we going to talk about today? Just want to start off by acknowledging the funders, because without the funders and partnerships, it's very difficult to do this kind of work. And so this work is being done with the support of Bodmer Foundation, obviously with WHO coordinating. And this Y-Check program that I'll be talking to you about, at least the Ghana story of it, it's not only Ghana, we have this similar story in Zimbabwe and in Tanzania. So there are 3 African countries that were involved in this project that WHO was coordinating. I'm just want to kind of orient us in terms of the way I'm looking at this talk and the things that I would try to touch on or to bring out from the talk, and just my thinking around systems and obviously how to navigate multiple layers, and especially when you're designing complex interventions like this. I also want to reflect on the fact that it's an intervention design, but we needed to have an equity lens in thinking about who gets this health checkups intervention. And then also something I really love a lot and guides my work, the Ubuntu principle or philosophy about how that was used to underpin our co-creation approach, and also highlight the fact that we can generate knowledge from the global south, and clearly this is information that WHO needs to be able to make decisions going forward. But then finally, you would see some ideas of how just being pragmatic in terms of our approach to this. As I said, this is a multi-country study. We need to think about what would work for Ghana. Things that I would like you to focus on, and especially that we also have our students here as we go along, is try to pick out elements of community engagement, youth-centered designs, co-creation, they call them, mental health integration of interventions like this, how to integrate mental health components into them, how to innovate and design health checkups, screening for adolescents. I think there's also some elements of implementation science in this, and also obviously thinking about scaling up. So this is where we started from, and this is a fact. Those who follow adolescent health will know that many adolescents do pass through the period of adolescence without actually having access to health services. And there's always this assumption that adolescents are very resilient and tough, and we don't seem to focus on them much. But we think, and now there's very good data that suggests that these actually creates missed opportunities. And you do know that once you detect things much earlier, at least for mental health, we know 50% of mental health conditions have their onset in adolescence. And so if you are able to detect earlier, definitely it means that you're able to then avert some of these challenges in later. But also the fact that most adolescents, just by their nature, at least in our setting, would always or mostly turn up in health facilities really, really late. So that is really what underpins it. But what is the background to this? What is really the context? The fact is, WHO, by its own guidelines, recommends at least 14 preventive visits or contacts with a health worker once you're born up to 6 years of age. And I think it's sometimes even up to 10 years of age. But after age 6 years, that becomes quite disparate and distorted. It's not a very clear program of contacts or routine contacts. But what we do know, at least we know that tetanus and HPV vaccines are targeted at some adolescents between 9 and 15 years, and also 9 and 14 years. But also beyond the age 30, there are some programs that also target cervical cancer screening. What we do know is that I'm not even sure there's many, actually. I'm going to have to look at that. But some high-income countries do have national recommendations, and I'll be sharing with you a few of them on adolescent health checkups and as a program of work. But again, this is usually based on expert opinion, and again, probably not based on what the adolescents actually say or want. And so the examples of some of these programs I have just been alluding to. So there's the Bright Futures program in the US. This is, you don't have to try and read this, but this is just to highlight the fact that there is this program in the US that targets young people and children, young people 3 to 21 years old for annual checkups, and they do a number of things in those checkups. We also know about the German J1 checkup, which targets 13 to 14-year-olds. And so the question is, why the difference? And clearly, I'm showing you differences in age, 3 to 21 years. And then there's another program in Germany that deals with 13 to 14-year-olds. And so there is a question mark there, and what informed this is just really not very informed by data. I checked about Canada. I can't remember if there is a routine health checkups for adolescents, but I know there are guidelines, or there's the encouragement that of some texts to let parents know why it's important to get the adolescents to have health checkups or to visit the health facility. But there's no written guideline on how to do this in Canada. So the question based on this was then for us is, and WHO obviously leading this, was asking the question, should WHO really be recommending this? And how do we do it? So that was one of the key, well, in fact, that was the main question, and that's really what we've been trying to answer till date. And so some of the questions we thought we could, if we're able to answer that, would help us with the data to make this decision, or for WHO to make this decision, would be essentially, will they be effective and also cost effective? I think sometimes we don't policymakers are very interested in the economic evaluation of most of these programs. So, what's really, and if that's the case, how many should we be thinking about? At what age group? I've just shown you the disparate ages in some of the programs in the US and Germany. At what age group, and what should be the content, and who should decide that content, and what should we be doing across geographical context? Should it be one-off guideline, or should we have guidelines that fit high-income countries? And also the setting, where should this be done? Should it be schools, health facilities, or communities? So these were our guiding questions going forward. And so I'll be sharing with you how we try to deal with this. So we had 2 phases of research. It's actually a 3-phase program. We just finished the 2nd phase, and now planning for the 3rd phase, which we are still not sure about because of design issues. But I'll take you through at least what we've done. So the first phase was really the formative phase, as most of you here already know, trying to ask the important basic questions about what should a health checkups intervention look like for adolescents, what should be the content, just along the lines of the questions that I posed earlier. And then the 2nd phase was to then design an implementation research to try to answer questions about how can we implement this and what should we be aware of to make sure that it's properly implemented. So that's the kind of thing I'm going to be talking to you about. Guiding us, obviously, we needed to think about what really we are looking for, what are we heading towards. So our theory of change of a health checkups intervention is that we are hoping that there will be an improved health and well-being both in the short and the long term, because of the problem that I already characterized. In our thinking, these are some of the moving parts that we have to be thinking about. We have to have an intervention package for young people. We have to think about on-the-spot treatment. We have to think about providing counseling services. We also have to think about a health checkups that allows for referrals onto other services. And also we think about a digital health club, which we couldn't quite do yet, but we're still thinking about it. As I said, we're thinking about either schools or communities, and adolescents, younger adolescents, and if you like, older adolescents, but also adolescents in communities as well. We're very mindful that there are some important context factors that we have to be aware of, but there are also some assumptions that we were going in with this with. Because it's a research and it's very well designed, we're thinking about measuring outcomes, both at the medium term at 4 months and also long-term outcomes after 4 months. So that is how we theorize that our health checkups intervention will work or would lead to our intended impact of improved adolescent health and well-being. So where did we do this? How did we do this in Ghana? So we, Botner was very, very clear that they would want this work to be done in a secondary city. And, secondary cities now is becoming something very, very topical when it comes to development discussions. They're just cities where populations, the different definitions now, but minimum of 100,000, definitely not the capital city, but also has infrastructure that resembles a capital city. So we picked one of those cities in Ghana, which is called Cape Coast Metropolitan Area. is one of the cities in the coastal belt of Ghana, as you can see, that's the map. And Accra is somewhere up there, the capital city. And then we looked at 5 communities across that city for this. And within those communities, we first selected the communities, and then obviously with local involvement. And then based on that, we then selected the schools evolving from those communities. So some of these samples show you how we selected the schools and the communities. Part of what we had to go through or to apply, obviously, this is research, so we had to apply existing models or frameworks of how to go about this, and we definitely borrowed on Hawkins' framework for how to design interventions, human-centered interventions. And just a quick reminder for most of us here, the 3 key components of that, or stages of this approach: evidence generation, in terms of distilling the evidence and consultations, and then based on that, you then go on to use that to co-produce what you are thinking about developing and what you've evolved. You then try to prototype and test it before you deploy it. So this is exactly how we followed it, and so we did quite a number of things, from evidence reviews, looking at the existing evidence about adolescent health checkups in Ghana, or adolescent health policies, both in Ghana but also in the study area. We consulted a number of groups that I will be sharing with you very, very shortly. And so our approach was really very, very much bottom-up in terms of our co-production approach. We started with our adolescents, and those are the voices we wanted to hear from first. So our very first set of workshops was really with adolescents and their parents, and essentially trying to even get to understand whether this concept of health checkups, and this is something that really, it was interesting when it came up in these discussions, that they don't even, most adolescents or most young people, at least in our part of the world, do not think that you need to go and check up and have a checkup or check your health. They think that the only time you go to the hospital is when you are sick. That's the only time you should go to the hospital. So this concept of health checkups was not really that very common, but of course we then used that to do some teaching. And once we did that, they embraced it, and then they started telling us what they would think or what they want to have in that health checkup in terms of the content, but also the setting and the delivery, but also they shared with us what kind of barriers. We then followed that with another workshop, another set of workshop with, if you like, the policy people or the health services and the schools and teachers and also NGOs, essentially providing them the data from our first workshop or what adolescents were saying, and then asking them what they felt about that and whether this aligns with existing practices, policies. But also we were interested in understanding whether they could share with us some barriers and facilitators to how this would be done through our key informant interviews. And then we went on to do a final validation workshop, having distilled most of this information. We then had all the stakeholders, including the young people, in one room, and then we presented, this is what you're saying, this is what you want to have it there. Is it still your thinking? Do we need to make any changes? Has any new information come up? And that was the goal of that final validation workshop. And from there, we didn't end. We actually had to get the buy-in from the people who make all the decisions, or who hopefully should take Y-Check forward if we were to find that it was useful. So we had engagements with the Ghana Health Services, the directorates of those who fall under this, and obviously the Ghana Education Service, to let them know about this. But also, very importantly, because we're going to be doing this in schools, we needed their permission to be able to access the school. So this was important that we made them know that we're not doing anything that is potentially harmful, and just to assure them that this was something that is likely probably they will benefit from. So this is some of the sites and the sites that we captured. So this is a typical PLA approach. They were discussing, from the discussions, they then go on to try to cast their votes on what they think the conditions. So these were a list of conditions. So literally we gave them pebbles or stones, as you see there, and they were just supposed to then go, each of them, and place the pebbles where they think. So they give them 10 pebbles each or 10 stones. And so if you felt that, for instance, mental health or background information, felt that is the number one thing you would want to see in a health checkups intervention, you put all the 10 stones on that. If you felt that you wanted to spread it out because you are ranking what you think is important, then you put the stones along that. And then, so that was a scene where they were doing this. Mind you, just what the reason why they are wearing masks is because that was the time COVID had just started, and we needed to do this work. We couldn't pause. Of course, we paused a bit, but we just couldn't continue pausing. We had to start it at some point, and we had to ensure that we were applying all the COVID requirements. And so, yes, particularly for the young people and their parents, they were very keen on that, and the ethics actually ensure that we had to do that. So that is that process, and this is what that process then led to. So you would see what you see down there. We then did a count, obviously, with them, and then you would see the tallies up there, and will tell you clearly what the adolescents are looking at or things that they think are more important to them. Okay, and so yes, at the end of the day, we had a long list of conditions that the stakeholders felt that we needed to have in health checkups intervention or screening intervention for young people. And these are some of them listed here. What you find in the green background are those ones that those are so not all adolescents got screened for this. The younger adolescents will not be screening them for sexual risk and HIV and some of these other conditions. This were for the older adolescents and those in the community. So that's why I'm just highlighting that. But the rest of them, they did. They were applied, or we applied to each of them. The two groups of adolescents, both the younger adolescents and the older adolescents, and those adolescents also in the communities. So about 33 conditions, that was quite a lot, but that's exactly what they wanted. And it was quite a struggle at some point. Even the ministry and the government folks wanted us to add some other conditions as well. But we needed to stand our ground and let them know that the reason we did this was really bottom up, and we can only do this when it's justified that there is when you apply the screening rules or principles, you don't screen for anything. You have to screen only when there is an intervention available. And so we had to try to convince them. Yeah.
You can only screen when there is an intervention available.
Yes.
Okay.
One of the critical elements or principles of screening is you just don't screen for anything. You have to be sure that at least there is an intervention that works or that is available for that.
Right.
Yeah. So that's one of the things that we had to consider, and obviously the prevalence of the condition is the burden.
Yeah.
So we went through a hierarchy of things before we arrived at all this. So essentially that was the phase one, and that's what we got. And so then we took this to the phase two, which was the implementation. And our target was 2,000 adolescents. We ended up with 2001, which was not too bad. So at least we had one bonus. It was really, as I said earlier, in school, adolescents 10 to 19-year-old. I think that compares to between 5 and 12 here in Canada. So elementary and high school. And then we had community adolescents as well. Like sometimes we call it emancipated adolescents, 15 to 19-year-old. And it involved 2 checkups. So the intervention, the Y-Check involved 2 checkups. First, you do have a screening, obviously. You go through the screening, which I'll be taking you through very shortly. And then based on the findings or the results of your screening, you either get a treatment then, or you get a referral. And so that's how the process worked. And we underpin this implementation, if you like, design, obviously based on the REAM framework. And so we looked at some of those outcomes. So that is just an example, a screenshot of the app. So we designed an app for this whole process. So you find adolescents, going through, come to register, and then as they go. So this was mostly self-completed. At least the self-administered part of it was self-completed, and until they got to the counselor issues, which I'll be showing you very shortly. So that was the app that we used. And this is really the process, just taking you through the process. So there was the registration booth, where that's where they'll come first, and then we check to see whether they have consented. And then we record their name, we take their IDs, we actually take a photo, a picture of them, so that is then used to be able to track the follow-up. And then from there, so we move to the laboratory assessments, where they are meant to collect urine samples, because we know that sometimes that can take a while. So the reason why we brought that forward was so that we can get the samples early, and so that those can immediately get and start being run. And so by the time, hopefully, the adolescent is finished, the results are ready. And then they then move to the screening tool, which is really with the app, where they self-complete questions around their mental health, psychosocial issues, around home, their diet. Quite a number of tools were applied in there. And then we also had physical assessment. So we try to understand, because that's a measure of potential disability, physical disability later on. So we had the grip test, but they also had the jump test done for them. And then from there, they went into what we then call the clinical review. This is where the physician assistants will look at all the results. And this was all programmed. So it was very easy for them to make a decision whether this person has met criteria for a condition that should be flagged, that needed to be acted on immediately. So two things they would do there: either they provide treatment on the spot. So for instance, if you were anemic, like kind of borderline or slightly moderate, not severe anemia, would normally refer out, but those who didn't have that will give them folic tablets there and then, right? So that's just an example of what they could potentially do. Depending on the scores, the physician assistant would know that, well, I think you need to see a counselor. So then they would ask the adolescent to go see a counselor, where they talk about their probably the mental health, but there's also substance use. And then we can have an exiting interview where we ask about the experience of the whole process, and so that obviously we can use that to do our analysis properly. So this is some of the examples of what really happens there. So this is an adolescent who's with a physician assistant being taken care of. And one of the things that we did in Ghana that the other countries couldn't manage to do was that we had our tablets, our tablet computers really syncing and talking to each other. So by the time you move to the next booth, all your data was already there. So they just needed to click your name, and then they were able to pull your records. So the other sites couldn't do that. They had to be moving tablets from one booth to the other, and that delayed the process a bit. But at least we were able to do this, and that's something that we shared with our other colleagues as well. And that's an example of the jump test. It was quite fun, as you can see. Some of them were really enjoying it, but yeah, they were meant to jump and how far they can jump, and then we measure that, and that's an indicator of whether they're having any physical challenges as well. But what we were watching that very closely and ensuring that they were not misbehaving, and that they were doing what was right and not stepping out of protocol. So we had our eyes on the ground on that. Just want to play a very quick video on that question that is really leading this talk about reaching adolescents, and essentially how well do we think we reach adolescents. How
you have to manually click the last one. Yeah.
As a student, I initially had a problem with depression, that I would prefer to be on my own, and during break, I would rather stay cooped up in the class or away from my mates. But then when I encountered Y-Check, I realized from their countless counseling and helpful discussions, it was depression. And actually that was a little bit unusual, because I thought it was a normal thing.
If you look at a number of interventions in the community, we realize that when it comes to the babies, infants, there's a program of screening for them, pregnant women and other, but adolescents really do not have any structured screening program where health-related issues could be picked up and early intervention put in place. So basically, what Y-Check intends to do is to find out how feasible it is to come out with a screening program that will work for adolescents between the ages of 10 and 19.
As a student, I had many challenges in studying. For example, my teachers and my peers thought that I was very slow in learning until I encountered Y-Check. So I didn't want to socialize with others. When I met Y-Check, I discovered that I had an eye problem. After that, I got my glasses. Now my education has gotten better.
Since we started, we've seen that yes, some of them had issues, but with Y-Check in the storyline, those issues are being resolved, especially those with mental health issues. Little did we know that some of them were even having suicidal cases or suicidal thoughts. Some were having relationship issues. But since we came in, they've been able to complain, or they've seen that this has been good, and now they are doing better.
According to the protocol, there are some cases that we have to manage on site. Cases like...
I'll leave the video later on. Okay, so that was just from their own voices when we captured from the young people, their testimonies about it, but those who like to see numbers as well. So this is what we call the yield of untreated conditions. So this, because it's a screening program, essentially this is what ordinarily you wouldn't have picked up until after your screen. So your screening picked up this, and that suggests that, and this is just a few that I put up in terms of those were about 50% in terms of the yield. There are quite a number, as you saw, the 33 conditions we screened. But these were the ones that were commonly picked up as conditions that we then had to work on and to intervene, like the PA was just talking about in the video. Quite a number. Anemia was quite high, but it's something that we are looking at, particularly being in boys, but something we are unpacking now about that data, because that doesn't seem quite right. But for girls, yes, it makes sense to have it that very high. And in terms of what we found before, so this was designed to have a 4-month follow-up. So after the screening, 4 months after the Y-Check intervention, 4 months after we went in there and then assessed them again, rescreened them again to see what was going on. And what you do find here, it's quite busy to read, but these are more of the behavioral type of conditions. And what you really want to be looking at is the prevalence ratio. That's to the right. So everything to the right means there has been some shift and positive shift. Anything to the left means that there wasn't. But you can see just on a very casual look that it looks like we did make some shifts in some of the conditions that we picked up. Just at the health checkup and what we then did for them, and hopefully at the 4 months, we saw some improvement in some of these other behaviors. So what are the implications for all this for scale up? There are quite a number of things that I want to highlight. First, the data suggests, and there's quite a number of data text that I couldn't add because of the time for this, but the data suggests higher susceptibility and that it is feasible to implement this program. I've just been showing you that it does appear that it is beneficial based on the shifts in prevalence ratios. And for me and for the rest of the team, we think that this suggests a scalable model for adolescent health promotion in Ghana. But there were some lessons, and one of the things that we found was the community component of the program. The uptake there was not as great. We did a lot of community sensitization and engagements, but still, it wasn't really. We're wondering whether this is something that we have to rethink going forward, and if this is something we would want to recommend. But something else we also did find that incentivization was very, very key. One of the things that we saw, and we have a PhD student who's actually working on this as well, was able to pick up the fact that if we were able to tie this to the national health, so Ghana has a national health insurance scheme. So if you tie this to the health insurance scheme, what it means is that one of the things they were not sure about is when you refer, even though we tried to tell them that the project was paying for that. So the project actually paid for the referral and the first treatment or intervention that was given at the referral. But some of them still weren't clear that they were wondering what the cost burden would be, whether it's still going to be on them, on their parents. And so that messaging needed to be done. And so the recommendation was probably if you tie to the health insurance and the project facilitates that they get health insurance, then that can take care of some of these concerns and worries. Peer educators we found was also very useful. What we realized that when we started, some adolescents were a bit kind of ambivalent and skeptical about the program, so they didn't consent. But then when they saw their friends doing it and coming out with goodies, because we gave some adolescent parts, we gave them toothpaste and stuff like that as part of their involvement. And then when they saw that, well, this is a good thing, then they all started running to the checkups. So maybe having that could also be one of the useful things. And a multi-sectorial approach, I think, is something that we need to really work on a bit more, because it was clear that between the health and education teams, they want to territorial things, and they want to claim who's really in charge and who's making the decisions. And for the adolescents, particularly who they really trust, we had data that suggests that they actually trust the school health program people because they're actually with them, and their parents trust them 100% more than the health folks. So that's something to look at. And just to leave you with this quote again from one of our participants, a parent who actually said very clearly how this intervention or Y-Check really helped in picking up something that they didn't even know existed with their child. Just leaving with a picture. We did our dissemination, and we had the key government people coming in for that as well, and it was really well taken, and they are hoping and looking forward to the next steps of this. So thank you so much. That's all time to give me now.
Great. Well, thank you so much, Professor Weobong. I think it's really interesting to take a look at that. Thinking back in Canada, what we have, I mean, I know we have eye tests, but we probably don't have a lot going. So I think it's a wise intervention from an international perspective. Yeah, did you have, in terms of the recruitment, were the schools more or less interested in being involved, or how did that go?
Yeah, so the schools were really, really very interested. And I mean, one of the things that I didn't add is that Ghana had already started a similar program of screening first year high school students. But, as you know, some of these programs usually do not really last. So there were challenges there. So when we came in, that we were coming with this Y-Check program, they were all excited about it. And also the reason that we were approaching this differently, what the government used to do is that they would just do the screening, they wouldn't even share anything with the students, no feedback loop. So that was a bit.
So you're saying somebody could need glasses,
yeah,
but they wouldn't know that they needed glasses.
So
the parents wouldn't know.
Yes, exactly. So and that data was just sitting somewhere. But when we went to see one of the government people, she was like, "There's so much data here. I know there's something we need to know and act, but no one is using it." So those are some. So yes, they were very keen, and as long as, and I guess it was really about how we approach things, how we involve them from the scratch. And then so they realized that this will not be disruptive, even though some of these checkups were being done during class school sessions. They were able to arrange it in ways that allowed it. Just want to acknowledge that I can see some of my team members online. So definitely, if you have anything to add, please ask for permission and add, yes.
Okay, wonderful. So questions. I think for you.
It's okay. Thank you very much, Professor. It's a great presentation. I have a few questions, but my first question, I guess, you showed us that there is there are 4 top and treated conditions like psychosocial anemia, etc. And one of them was epilepsy.
Mm-hmm.
That's like very, I would say, easy condition to spot, right? Like how come it went unnoticed?
Right. Well, because that is true. But there are a number of factors, some of our belief systems and our explanatory models for some of these conditions, right? Personally, maybe parents would not even notice that this is a condition that.
Oh, the sign of it.
Exactly.
Okay.
So that could be, and also, I think that's the assumption we make with some of these conditions. We think they're so obvious, and maybe obvious, like the stage where it's obvious is the ones that are very frequent seizures that one I think you can see, but there are other signs that suggest, and that's the whole point of this, is to early detect. So there are certain things. So the question, we have 4 questions. I can't remember them, but set of 4 questions, and any positive to that a question, any of those questions was a sign that you could have that. And so it's really, again, early detection. And so we're not waiting for, if you like, the chronic condition. So we're picking both acute.
Thank you. Looks scary, actually.
Yeah, it is. No, it is. And you are right. It's something just before this meeting we were discussing with our WHO colleagues, and we realized that it's something we need to look at. And I think it's about the way the questions are put together, and if you're taking any of them. One question is talking about even having a sensation of something. And so I don't think the questions were very specific, and something that we have to look into. So yeah, I wouldn't put so much on that. You're absolutely right. It wouldn't be that very high.
Okay, thank you, Professor. It was an interesting presentation. So my question is regarding the implication for scale-up. You mentioned the high acceptability and community uptake.
Yeah.
But then if you're thinking of incorporating into the Guinean National Health Insurance Plan beyond the programmatic evaluation, have you guys done economic evaluation to see the cost effectiveness and like economic value by incorporating it into the
Pisum needed to answer that question. I should have known that Pisum would be here to answer that question. No, we did. We did have, we collected cost data. I just didn't present it here because of the time, but we did collect cost data. And so we will be able to tell whether it is helpful cost-wise. But even that, I think we need to do a bit more. And that's why in my initial comments, I was like, even though this is a 3-phase program, we're not so sure about the phase 3. The phase 3 is really to then ask the important question, is this effective and cost-effective with a proper design? You can see clearly this was not. This was really just, if you like, a before and after that kind of thing. Yeah. So the question is, how do we even design studies like this? The ethical issues around that. And so we are thinking about it. We're thinking about what kind of design to use to be able to answer that question, because we know that policy people always want that answer. Is this cost effective? And so we are kind of tied to that, and hopefully we will get back, but at least some of the data we had suggest, I don't know whether this one is online, but from what he shared, it does appear that it is doable in terms of the cost. And if you look at what you are vetting against the costs of what you are putting in or you're seeing here, I think it makes sense.
So intuitively, one would assume early detection is cost effective.
Right.
Right, that's an assumption. But
that's true.
What I found out that the last 2 months at York, they don't care about that. They care about what the empirical data said.
Yes.
Right. So you have to be able to document that, right?
I agree.
Yeah.
That's exactly where we are now, and we are kind of we have some ideas what kind of design to use. Oh, only intervention teams had access to it. Oh, someone asked a question that Hannah asked. Oh, one of my team members just answered. That's good. Yes.
We do have a question online as well from Sylvia.
Oh, yeah.
Okay, maybe, yeah, Sylvia, you probably had your hands up first.
Yeah, thank you very much. And thank you, Benedict, for this presentation. It's just a quick one. So from your presentation, I could tell you'll be dealing with 2 big institutions, that is the Ghana Health Service, as well as Ghana Education Service. And when it comes to issues on adolescent sexual and reproductive health, which were some of the things I saw the kids and the adolescents listing, they tend to not agree on certain issues. So I'm wondering how you deal with such things, if it even came up, and how these things were addressed. Yeah,
that's a very good question. That's a very good question, Sylvia. And we did have those very tense moments with them about these conditions. I remember the director of the school health education program just telling us, this is a no, you can't do this. So for some of the conditions. So I agree with you, there's always that. But what I think what helped us was our frequent engagements and just presenting them the data and telling them what really we wanted to do. So they needed to give us permission to even access those schools. And before we got that permission, they needed to be convinced that what we were screening for is not anything that's going to create any trouble, particularly with parents or that. But yeah, I mean, I think we got. I would say that's really how we did our engagements. But the interesting thing is they were also excited. They also wanted even some other conditions to be added. And we have to diplomatically decline that, which is not easy to do in these situations, but we just had to use the data to speak to it. We said, well, we did our initial formative work in terms of the hospital data, this prevalence. Some were asking for screening for potential breast cancer. Now, we had to argue, we had to push back that the data, particularly for young people, it's not that very, it's not I think something to be worried about, to put so much investment in the screening program, because you wouldn't find that many people like that. Of course, there are always going to be one or two people. But for a screening program and decisions around that, you have to look at the collective.
Yeah, that's fair enough. Okay, go ahead, Elsie.
Thank you. That was an excellent presentation. I was really inspired by, especially your phase 1 of the co-creation process, and I know it touches upon that in the reading that you shared. I was just curious if you have any advice for, that's something I really hope to do within my research as well, with children. At the scale of more PhD level, how can you incorporate these co-creation strategies of having them be a part of the research process when there's kind of some constraints over time and budget and feasibility?
Yeah, I guess I can only share our experiences because there's no one answer to this. And Hannah was the one who handled most of that bit of the process evaluation aspect of it, and some data on what we did. But I would say that it's I guess it has to do a number of things. One, the incentivization. What is the incentive in this for us to participate in this? When they came out with their first list of what they want and how they want it, it's most clear. Everyone was saying free. That the word cloud free was like the most voted for. So I guess it's about how you present it that way. But yes, getting adolescents, particularly young people, in participating in the research, it's a very, very big challenge. And I know a colleague who in fact, one of my PhD students when I was in Ghana, is looking at that. What are some of the challenges, or why is it an issue for adolescents in participating in some of these programs and trying to unearth it? One of the things she's coming up with clearly is just knowing and just information and being aware and being properly informed of what the expectations are. She's finding that to be quite something that, and also the parental or the parents, essentially the whole thing about the enabling environment. So you have to create that. You have to create systems that allow them to participate and to be wanting to be part of this. And so having parents buy-in, and in our setting, it was quite unique, because in the consenting in some places would be that you let, especially the younger ones who can only give assent, you needed to get their parents' consent first before they then provide the assent. Even though we're being asked by some other people to get the adolescents first. The adolescents' decision is what is key here, and not the parents. But we have to push back that there are cultural issues around here. You can't do that in our setting. It means literally you probably not get anyone turning up. So some of these things you have to be aware of. So be aware of some of these cultural factors as well, and then make some decisions around them.
Thank you.
Yes, go ahead.
Thank you for your presentation. So my question is around any results that you were surprised about. So you told us about the anemia with the boys and girls, so that was a little surprising. I wonder among age groups if there were certain conditions that you thought were maybe surprising to see, or even between those in school versus the community, differences there.
Yeah, that's a very good question. There's a lot of data. We're still very much on mining it and unpacking it. But I think what we are seeing, obviously, some of the things we're seeing, and again, it's something that we're still trying to figure out why. That's the whole thing about research. You get your data and then you try to make sense of it. But one thing that I think is surprising, and surprised most of us, is the prevalence of visual acuity challenges. So vision impairment was really very high. I think in the 20%, which the data doesn't suggest that, especially in our part of the world. It's around, should be hover around 7 to 8%, I think. So that was something that we found surprising, but it's something we are looking at. We're trying to understand what could be the issue, and we should have a way of checking that. So what we did, as I don't know whether I made that very clear, the referral pathway was such that, so this is a screening, so they only have just how many minutes, right, with adolescents, and they need to do certain things quickly. But then, depending on what they find, they refer. So at the referral facilities, we do have data at the referral facilities that will be able to tell us whether they were able to validate or confirm some of those things. So we should be able to check that in the actual prevalence. But that was one thing that we're all surprised about. Obviously, the epilepsy is another one. But in terms of the type of adolescent, if I can put it that way, the emancipated and then the school-based adolescents, I think I'm not sure. I think it's because obviously we for those ones we screened them differently, and some of them had questions around HIV and all that, and we found quite a very low prevalence. I don't know if some of my colleagues here can confirm to that. We found a low prevalence, which I think it's a good thing, but whether that is really the case or not is something we want to unpack, given what we know about that area.
Are you planning to link this data with the maybe administrative data from health insurance provider and see if there are any trends or correlations?
Yeah, that would be the ideal. That would be what we should be thinking about for our next steps, which is indeed what I mentioned earlier about the Digital Health Club. That was supposed to take care of that. That was supposed to help us, because one of the things that the health people told us, the government people told us, that we come and do these programs and we go in, we find out what it is, but there's no program for follow-up. Like we are now unable to track these people. And so we told them that this is what the Digital Health Club would do. So that's something we're still working on. But it's a good point. We should be able to think about how to integrate it within the health services. Because like we said, at the end of the day, they're supposed to be working together, and we do have them going to health centers. So we should be able to kind of have that integration. But it's something to think about, and maybe the next proposal we have to write and try to keep that cohort going. Yes, yeah. It's very good.
Go ahead, Michael.
Going back to the beginning, some more of the conceptual question. One of the fundamental needs of the participatory approach is that everybody needs to know what they're talking about.
Yeah.
And in this instance, as you said earlier on, the adolescents that were assembled need to be informed about what the general concepts that. Yeah. So this is a fundamental challenge because we have to navigate the issue of bias when you're trying to make sure that what you're talking about, people can know objectively about without imposing what you're trying to get at. So I was trying to understand how.
And making their own informed decisions. Exactly. I see what you mean.
How this was addressed.
And I guess that's in reference to even the concept of health checkups, right?
Well, even the concept of health checkup, and but further to that, and thanks for adding that, further to that, the concept of mental health. Right?
Right. Well, there is the concept of health checkups. I think that's something that we need to deal with, and I think as researchers, it is important that we get our measures right. So I would see that as a measure. And so the design of the measure has to be done properly so that you can elicit the right responses. Now, we couldn't go and start talking about health checkups when they don't even know what health checkups are, right? So it was important that we needed to do that. And it wasn't challenging when we then sold the concept to them that it's not. And they told us that they thought that the only time I should be worried about my health is when I'm sick and I go to hospital. And I said, well, there are ways that you can also just ask, someone can ask you a few questions or just do a quick test and be able to say whether you need to go and see a doctor. So we try to do that, and we told them the benefits of that. And so that's how we navigated that. In a way, well, we needed to push that agenda because it was important. It was important we got them know what we are trying to do before. So yeah, maybe some bias there because we wanted them to learn about health checkups and then respond accordingly. But I think it was for good reasons. In terms of mental health, see the concept of mental health, it's not alien, right? So they, like you saw the young person saying it. I think he didn't connect certain things, certain experiences or emotions he was going through. He couldn't immediately say that this was probably a mental health issue until he stepped. And there are quite a number of them like that. And maybe that's the reason why an intervention like this, integrating mental health component of it in an intervention, a routine health checkups intervention like this is also very important, because there are quite a number of people probably walking around who don't even know that some of the symptoms they're experiencing could be potentially something that could take mental health diagnosis. So yeah, but yeah, obviously, if you have ideas, let's discuss how we could deal with these. Anytime we go to meet our participants, how we ensure that we are being very, very open and frank and playing at the same level, if I can put it that way.
Didn't one of your slides have 72% of the population that you were measuring and health issue, mental health?
Psychosocial, yes. So that would have been the psychosocial bracket. So it's a mixture of many things. So we have to then break that. So we did look at depression and anxiety separately as domains, but that would have been psychosocial, even the home environment and what they think about it, whether they have friends, what they think about their home environment, or whether they have friends and things like that. So all that went into that domain. And so, yeah, that needs breaking down.
So it's wonderful to see that the co-production, especially backing up with data. You mentioned about the use of prevalent diseases within the community that is going to kind of lead into what are the interventions to be kind of included. But however, as a national scale up, there may be regional differences, disparities, and the needs for the whole country when it is getting scaled up. Whether there is any consideration of flexibility within the intervention package has been considered, or anything in the plan.
That's a very, very important implementation question or scale up question, because you only test and know how your intervention works within the context that you tested, right? That's always where you take it from. Obviously, you can always look at what are similar. You know, there could be factors that are similar across, and so you can make a good guess that is likely to also work similarly in those settings. Nonetheless, I think it will be important to think about whether, I mean, you can't, it may be challenging to want to do things that are very tailored to every region. It may be challenging. I'm not saying that it shouldn't be done, but it could be challenging. So in terms of just being pragmatic, what then do? You need to think about maybe some of the conditions do not apply, maybe in the northern part of Ghana. And so if you're thinking about the routine screening, you could potentially drop those ones. So that flexibility should be there. And I think I like that idea. Yeah.
Yeah, you know, I recall that there was, in some school boards here in Canada, they did put in mental health teams in the schools. And one of the critiques, though, was that they overtreated. Like, you know, ADHD can be a problem, but sometimes it's very mild and it's not even worth treating. But they
were just picking everything.
Exactly. And medication for anxiety that can be antidepressants, and those can have side effects. So I'm just wondering, was there any concern about overtreatment?
Yeah. Well, that's a bit that, and because this is my area, trying to see how I could even learn a bit more about this myself for a future program, whether to integrate or to have a standalone. I think integration, which is really what we'd want. Well, in our situation, the more of the counseling was the counselor on the spot, really what did most of the trick. I would need to look at whether some of them were referred and where they were referred to and what they did for them. We do have community mental health nurses and most of the health. So we mapped out health facilities within the area that we're doing, so that and then we talked to them. So we had an agreement that we'll be sending our folks to. So we already knew who or where we'll be sending them to. So we can check that and see whether there was, what type of treatment was given to them, and whether they were potentially misdiagnosing but yeah, it is possible that can be done, or that could happen. But that's why it's so important to follow the protocols very clearly. And so in our case, it was the only time that you needed to refer was when there was a very clear element of suicidality and obviously very high scores. You refer, if not, the counselor had to do quite some work even on the ground there.
Right.
And then someone could ask you, is that enough to make a shift or a change? But yeah, these are things we can discuss.
Yeah, I think the guidelines are, what you really have to focus on if you want to avoid that.
Yes, exactly.
Okay, great. Well,
so go back to this hand, but
okay, all right.
All right, thank you.
Go ahead.
Just a very quick one. Thank you very much for your presentation, Professor Weobong. It was very interesting. I like the way that the process that you went through to select the health conditions to be screened for. I think that was really good. I'm very familiar with the Nigerian context, which is similar to the Ghanaian context. And I think also generally in global literature, adolescent health, when talking about adolescent health, a lot of attention is given to adolescent sexual and reproductive health.
Yeah.
And many of the other things like nutrition, which could be related to anemia that you mentioned, and mental health and oral health and vision and things like that you mentioned are often neglected. So I think that process was quite important to also ensure that you are managing the health of adolescents as a whole.
More comprehensively.
Yes, in a more comprehensive way. And a quick question on the choice of a secondary city.
Yes.
For the study. Was there any specific reason for that?
Well, like I said, the funder said we should do it. I don't want to put it on the funder, but at least I have to say that the funder was very clear that it has to be a secondary city. And if you know Botna, their interest is really in secondary cities, and most of their funding and what they do there goes to that. So that was really the key reason. It wasn't really because and there are quite a number of secondary cities in Ghana, but then we selected Cape Coast. That was obviously because it was easier, and we already had, so some of my colleagues in Cape Coast, we already have a good team there. So in terms of the structure and the setup, it was easier to do it there.
Okay, well, thank you so much, Professor Weobong.
Thank you.
Great, and we look forward to your findings.
Yes, absolutely. Yes. Look forward to that. Yeah.
So can you make general assumptions around the world? Like if I'm in the Philippines with the same conditions that you're having in Ghana, can you make general assumptions about that from your research?
Again, it will depend on the context. I guess I will always go back to that. It will depend on who we are talking to in the Philippines and what.
Yeah.
And if it's necessary, then you can take that leap of faith to make that general assumption. But I would always say that for implementation science and most of the work we do, context is so critical. You can't overlook the role of context. So those assumptions you have to be probably careful about.
When you use the word depends, you sound like a tax accountant. Context is critical.
Yeah, for sure. I imagine there could be like some different conditions.
Yes.
Prevalence within certain populations.
Yeah, exactly. And even the infrastructure is the infrastructure to deal with different. And we know if you don't have health facilities, what do you think? How do you then think about your referral pathway? There are lots of other things. Should we then aim to do everything there? Should we bring all the clinicians there to the site and make sure that you set up camp literally there? So some of these things you have to think about.
Yeah.